I'm an abdominal transplant surgeon performing kidney and liver transplantation and pancreas. I'm not a thoracic transplant surgeon. And I'm going to talk about neonatal organ donation and outcome after transplantation. This is a little bit of odd topic, a rare topic, but I think it's an underutilized and underappreciated source of very good organs. And I just wanted to show you a little bit an overview of the field and a little bit of the work we have done at Karolinska. And also wanted to ask a question whether someone in the ear and transplant child community has maybe an unpublished good experience of transplanting these organs. You all work within organ transplantation, and we're all aware that the need is far higher than the supply, and especially, and that is true in Scania transplant where I work, and especially for the very young children, mortality on the waiting list is higher, even when our mortality is quite low in Scania transplant. And that is also driven by very young heart recipients. What we can do as transplant surgeons and in the donation community is to try to increase organ availability by, for example, introducing DCD programs. DCD has been introduced in the recent years and has increased organ donation, especially in the Scandinavian countries. And today, 20 to almost 40% of the organs come from DCD. So that has been a very good addition. We have living donation and for example, split liver techniques as alternative surgical techniques. And we use more and more extended criteria, donors with older age and in liver transplantation with a higher degree of steatosis. So today I would like to talk about neonatal organ donation. The newborn period are the first 28 days of life, and that's the most vulnerable period in the life. And the majority of pediatric deaths occur in the neonatal period. So more than roughly half of the deaths in children under 5 years occur in that period. And the cause of death is premature birth complications such as asphyxia or trauma, neonatal infection, congenital anomalies. And when you look at the death rate in relation to the population, and these are US data, you can see that the death rate is almost equal to the death rate of a 60-year-old. And 60 is actually the median age of our donors, our deceased donors in Sweden. There are two common pathways, the DCD and DBD pathway in organ donation, and it's a matter of how death is diagnosed. In neonatal organ donation, DCD is the most common pathway due to the fact that herniation does not occur in the same degree due to the fontanelles. Also, the legislations and the guidelines for, and also the practice is not very well established in many countries. For example, in Sweden, where I'm from, we actually don't have specific guidelines for DBD donation in the neonatal period, and it's not practiced. There's no regular practice of neonatal organ donation in Sweden. DCD, there is a pilot, the DCD project, and that is possible. However, we are required for neonates to have an additional 20 minutes wait time from withdrawal of treatment until death can be declared. In contrast, other countries such as Great Britain, US, and Canada, they have clear guidelines for DBD, which are very similar to declaration of DBD in adults. However, there's usually an extended period of observation. So what is the potential of neonatal organ donation? We recently summarized the experience in a systematic review, and there are 8 to 9 publications looking at the potential of neonatal organ donation. And it turns out that about 6 to 60% of the deaths in neonatal care are potential organ donors. Some of these studies looked into organ-specific criteria and can see a difference here, whereas others have not looked into that. There's only one study which looked into DBD criteria in the neonatal population. I want to highlight the publication by Bennett, who specifically looked into pediatric death. And what you can see here is that the neonatal ICU, that the agonal time, which means the time from withdrawal to determination of death in the DCD pathway, is longer for the neonates in comparison to other pediatric deaths. However, when looking into realized organ donation in this population, it can be seen that the referral rate is much lower for the neonatal deaths, and also in the cases where donation was evaluated, a higher degree of donors are declined due to infection, size below 2 kilos, and genetic syndromes. We also looked at the potential in Sweden using the neonatal quality registry in Sweden, and we looked into the years 2006 to 2016 and found over 2,000 deaths. We excluded 1,753 of these for several reasons, the main reason being born below 27 weeks of gestational age. We then performed a medical chart review of 308 possible donors, from which 223 were excluded, and we could come up with 85 potential neonatal organ donors. We looked into organ-specific criteria and found that 39 kidneys, 29 livers, 18 hearts, 80 hepatocytes, and also islets could have been donated from these donors. So there is a reasonable potential, and when calculating, when calculating on the numbers per million population, we see that kidneys, for instance, could result into 1.9 kidneys per million population, which for Sweden would mean a 10% increase in organs for transplantation. So what is the experience of neonatal organ transplantation? Well, the experience, at least the published experience, is quite low. We surgeons like to look and judge the organs macroscopically, and on the right you see nice looking young neonatal organs in contrast to the adult organs we sometimes use for clinical transplantation. They are of course much smaller, and there is a hesitation that the organ function is not sufficient due to the organ size, and also that the vessel size is smaller and that the risk for thrombosis is higher. We summarized the published experience of neonatal organ transplantation in this review, and there is quite some experience for both kidney, heart, liver, and hepatocytes from neonatal donors. It's usually small series. The results can be excellent. However, for many organs, at least the kidney and the liver, a higher degree of vascular thrombosis are reported. I would like to highlight one publication by Nia Samad and his team from Leeds, who have reported on a series on neonatal organ transplantation using kidneys, en-bloc kidneys. And here they describe their surgical technique. They have reported their results in 2 cohorts, these being donors below 5 kilograms of weight and donors above. What you can see here that the younger donors have a higher percentage of DCD donation. In the below 5 kilogram donor cohort, 2 vascular thrombosis, graft loss due to vascular thrombosis are reported, and 1 PNF. And in the group above 5 kilograms, one graft was lost due to thrombosis, and 1 to poor initial function, and 1 to rejection, and 1 to chronic graft nephropathy. What is important to point out is that these grafts are not or have not been transplanted into pediatric recipients. They were transplanted into adult recipients with a median age of 33 and 30. And the results were very good, with a 1-year graft survival around 90%, being not statistically different between the 2 groups. And what they could also report is that the eGFR improves over time within the first 12 months. This improvement of eGFR has also been reported by others. This here is a cohort of 130 transplants, which are pediatric en-bloc kidney transplantations. From a US single center experience, and here you can see that up to 4 years you can see an increase in eGFR. And also from other older studies, we know that short-term survival of pediatric en-bloc kidney transplantations is inferior to adult donors. However, in the long run, these seem to have a superior long-term survival. I would like to switch to liver. Here the experience is very limited. There are actually only 2 publications, one from the US from the early 90s by the group of Stasel, and one from a Chinese group which is more recent. Here they reported on liver transplantation from neonatal donors and looked into which is into group 1, which are the neonatal donors, which are below 1 month of age. Group 2 is 1 month to 3 months, and group 3 are donors between 3 months and 12 months. These were both DVD and DCD, and graft recipient to body weight ratio were between 2 and 3.5%. The recipients were very small patients or young patients, mainly with biliary atresia. And the reported patient survival and graft survival are good. They are possibly slightly lower compared to older donors, and the group also reported a higher degree of arterial thrombosis in these cohort. When it comes to the heart, the neonatal donors could be a very important pool of donor supply, especially for the very young recipients, where mortality on the waiting list is the highest, up to 20% in some reports. However, the reported transplants from these donors the experience here is also low. There's a older experience from the Loma Linda Institute, where they reported very excellent patient and graft survival after neonatal heart transplantation into neonatal recipients. And they hypothesized that possibly neonatal immunological tolerance could be the cause for this excellent long-term survival. Many of these donors were anencephalic donors, which were considered brain death at that time. However, with the introduction of pediatric heart transplantation from DCD donors, this neonatal donors could actually be a even bigger donor pool. You're probably familiar with this publication from 2008, which was one of the first reporting on DCD heart transplantation. And we know from the recent, mainly US experience, that DCD heart transplantation in adults is increasing significantly in the recent years. And that is mainly due to the fact that ex vivo machine perfusion, or TA-NRP, allows to evaluate these hearts and transplant them successfully. And recent reports show that the patient and graft survival is excellent and in comparison to DBD heart transplantation. And last but not least, I would like to report on a recent Spanish experience where the technique of TA-NRP was used in a neonatal donor to perform an ABO incompatible heart transplant, which was successful. So in conclusion, neonatal organ donation offers a promising opportunity to expand the donor pool. The number of potential candidates is much, for DCD is higher than for DBD. However, the utilization rate is much lower. Barriers for the low utilization might be that we lack clear guidelines and knowledge and awareness, at least in some countries. These donors are often not referred, and there might be a reluctance within the transplant team to accept these donors. Kidneys and hearts from neonatal donors can be significantly enrich the donor pool. Liver transplantation is associated with a higher risk of hepatic artery thrombosis, and here we need more research and more experience. And it may be that improvement in surgical techniques and antithrombotic strategies could improve the results even further. And with that, I would like to conclude, and I'm happy to take any questions.